And hello, welcome to the Scientifique podcast. And this is the next episode in 2026, and we're ramping up for some really exciting topics we want to discuss. And here with me today is Timmy Beams, founder of Scientifique, and my name is Bart van Buchem. I'm a pain specialist physiotherapist like Tim is, and we're sharing all we know and think that is helpful for anyone working with patients in pain in a clinical practice. So today's subject, which is an interesting one, and we discussed this a bit, and then thinking, well, this is such a big thing. So we're going to talk about uncertainty and comfort with uncertainty, and building trust if you say, I don't know, which could be, we think is a good thing, especially in the field of pain and treatment. So let's put it up from here. And I think one of the most frightening things a clinician can say is, I don't know, unless it's said well, right? So we think we should advocate for that, the fact that I don't know is not a bad thing, and it can actually set the scene in a very positive way, especially when there are reasons for the uncertainty, which we just probably have to embrace in some way. So my question to you, Tim, in terms of uncertainty, just to give a bit of what would you consider to be uncertainty by definition, just to make sure that we're talking about the same thing, because I think uncertainty could mean different things for different people.
Yeah, I suppose we're, from a pain perspective, what we recognize is how varied presentations can be, how so many things can influence an experience of pain as well, that particularly if we are only meeting someone for the first time, we can't possibly know and understand the sort of multiple different elements that can make up that pain experience for the individual. So that on one level, that's kind of what we're saying. I suppose there's a what we're not saying that might be interesting as well, which is, it's not about being incompetent and deliberately vague with saying I don't know. So I think there's a sort of caveat, and perhaps this is something that we're going to get into, is that it needs to be boundaried in the right way. So how you package the sense back to that person of uncertainty is as important as recognizing that we can be uncertain as well. There's a few, I feel like I'm going already off, but there's a few things, isn't there, that we probably preface, and we've certainly talked about this beforehand, that in terms of what is possible with that person is that it's not possible to image pain or test pain, but it is possible to image the skeletal system or test the nervous system, for instance. So there are things that we can know and we can give some clear understanding and some guidance for. But then there are some things that we don't know, and the sort of fuller picture and influences and contextual variation and what have you of a subjective experience is really where uncertainty sort of is fueled.
What do you think, to get to the clinical point of view, where you said, like, where does the fine line between uncertainty is like a normal aspect and accepted, maybe even helpful to address, versus unhelpful? Because there could be
Yeah.
a feeling of a pressure from my point of view, where I am as a clinician, where people like, tell me what's going on, yeah, or what's going to happen next. Is this treatment going to be helpful? Is this ever going to be better?
Yeah. Yeah. Yeah.
I can see that there's a little bit of tension. I recognize this from my day-to-day clinic, which is always a bit of a, yeah, playful balance.
Yeah.
And
Yeah.
that's a very positive angle for.
Yeah. I mean, and I suppose that, like, as I'm sort of listening to you, and I'm just running a scenario in my head of people listening to this episode, and then suddenly, like, the first thing they say to their patient is, "I don't know." It should be bonkers, wouldn't it? And because people will come often fueled with uncertainty of, what's wrong? Am I going to get better? Is this person able to help me? And there is a bunch of different uncertainties there that we have a role in um, in some sense softening. And I always think about uncertainty in ourselves and our experiences is it's a beautiful breeding ground for anxiety and worry and what have you. So really understanding what it is that person wants is important. What are the answers that need, what are the questions that need answers for? So that's that. So there's a skill in itself in someone listening well, asking the right questions before we start saying, I don't know. So I think that's an important part of a process, isn't it?
Yeah, and I can see myself sometimes maybe still doing it, over explaining. That turns out to create certainty, and then it turns out to build uncertainty because he's losing your words, basically getting in a rabbit hole.
Mm, yeah.
But always felt that if there's confidence, and I think I think is uncertainty doesn't equal, or uncertainty or sort of certainty doesn't equal confidence. And I sometimes you might see in also in our graduation programs here that newly grads, physio or doctors trying to use their confidence and misplace it in trying to create certainty, which is, and it's in a sense, it's not certainty because there is this uncertainty. We don't know if it's going to help, but promoting it very confidently and misplacing it could be problematic because people say, oh, I don't believe that, even though you make it look or sound like really easy. And I've had that in the past. Definitely have these experiences where you are trying to make something certain where it's not, right? Basically, creating false certainty.
Yeah, so an
That brings us to the
unfounded certainty. Yeah,
yeah,
yeah, yeah.
versus the felt safety. So if we put this in contrast, where is there any models or rules of engagement in terms of where false certainty versus felt safety is a thing, or we can use as a framework? What
I
would
think that
you use? Yeah.
there's principles within there, aren't there? If you only have one way of explaining things, when something starts to appear different or doesn't is unexplainable, doesn't follow that pattern, then we soon come up with a few problems. So having some flexibility in our way of thinking and making sense of what's going on in that person's world is important, isn't it? And I suppose from a pain perspective, a typical linear cause effect relationship is very common for people to use to make sense of pain, where persistent pain often it's more challenging, it's more complex than that. So that can be a place. And it's not to say that linear models don't have a role to play, because absolutely, at one point in time, and maybe one point in time in that person's assessment, we use fairly sort of objective black and white questioning, and we want to know specifics. But then there's a skill in being able to then come away from that as well, and hold a bigger picture, and recognize the complexity within that individual or an individual.
Yeah.
Um,
It still does that question, for example, when is this treatment going to help?
yeah, yeah,
I would probably think, well, what does help mean, right? In what sense it helps? I just have to admit, I'm a bit nerdy in that sense that I love sort of backing up some science just to give, well, the evidence has shown this, but in your case, sort of, you can't say it's not going to work for sure, right? Even if it's on pain intensity or activity, but I think it does give you some framework where you don't have to rely on the evidence or the clinical trials alone, obviously, but it does give that. Sometimes like I sometimes feel sorry about, like, oh, I don't know this is going to work. Probably not, because the trials have shown not to be effective. So better not. Although you might even give an opportunity, or you avoid someone to take an opportunity, maybe to start their journey and becoming more confident in themselves in their treatment. So in some way, probably we should not be too pragmatic over there, and exploring what the reason is why people got into the phase where they are now with you at that stage in their journey. Um, so,
yeah. Well, that's yeah. So I think you're bringing up a point that I often introduce with patients, but even before we're working together, is there is a problem-based approach, figuring out what is it that caused me to get into the place I'm at. But that isn't necessarily, find that out isn't necessarily the solution for how am I going to, move on and recover. So a solution-focused approach is a bit different. And, we can have some relative certainty perhaps in why someone comes to this place, but over time that becomes a bit more difficult to make sense of as well, doesn't it? And then the solution for someone, and particularly with things that are complex and persistent, is that we don't know for sure that this is the solution, this is the way forward. But it's an uncertainty, I suppose, and the phrase that we've often used is curiosity, isn't it? And exploration is we get more confident through our exploration and our learning over a period of time, but we can't be fully certain of it. And I was wanted to bring us back a little bit about certainty and reassurance, because some people, and I think probably the two of us aren't the best at this, is being super confident with everybody to say, I will get you better. I have got all the tools to know that I will get you better, because I know that even if I'm doing the best I can possibly do, that is not always the right way forward for this person, or it's not the right time in their lives, or whatever. I just know that there are variation in what can occur. But we can be confident in our knowledge and our ability to understand someone and situations, and that can create some reassurance. So creating some relative reassurance and certainty in our knowledge of where we're at is, I think, is important. And you don't have to just have experience for that. You build on this, obviously, don't you? But but being able to work with and recognize where you can build more certainty, more strength and assurance in your thinking over time is a skill that we can work.
Which is on the back of my mind. That's classical CBT treatment, right? So focus on the things you can change and not the ones that you can't change. Trying to create a and differentiate between these thoughts, because most of them are thoughts and to worry about, and where you can find reassurance and where not, which is a great way to start exploring it, right? Especially when someone asks you, so what's wrong with me? It's a huge question, especially if we deliberately don't know exactly what's going on, because we only can hypothesize. Even if, and I think even telling a person that they have nociplastic pain doesn't really give necessarily. It may raise new questions, or in some people they, oh, I finally got something, or it's a fibromyalgia, and we have gone through recently have a few sessions on fibromyalgia, where this uncertainty is quite a huge thing, right? It's such a big thing, uncertainty, because you never know what, and there may be some patterns, but it doesn't always follow the procedures that you would expect. Which I like exploring it, especially when expectations and uncertainty is a big thing. I think it should be a big thing in therapy as well. Start exploring and acknowledging that it is actually something to struggle. But there are strategies to, for example, reframing the question. And I was really interesting what you think, how you reframing these, like when people are asking what's wrong. That's maybe the real question is, am I safe? Or is it going to be even worse than this? Or can you handle this with me? Like having like a supportive question. So why does a diagnosis not always answer these questions?
Yeah. Well, like the first thing that's jumping out of me is hearing something doesn't necessarily make it real. You know, if you say to someone, you know, you're safe to move. Going back to our previous episode, you know, we've tested your movements and we've felt the tissues and I believe you're safe to move.
Mm.
That doesn't, you know, although you've given permission and maybe some reassurance and you know, your hope is there that you're reducing the threat value in that experience until someone does it. And then they get some feedback and some evidence in themselves of whether that is or is not safe to do. It's, you know, it's not enough. It's not quite empty, but it's often not enough for them. So being able to provide the evidence in themselves, the experiential process is a key feature. And I've said before, you know, there's ways of us learning to be okay with uncertainty. There's ways of teaching that in our patients as well, of being curious and saying, you know, maybe you want to have a guess at, you know, if I do this, how am I going to feel? You know, guess and then test it out, see how it goes. I always think of like testing my clinical reasoning out as I was younger. I used to, I was a bit geeky, but I used to have a little guess, and I remember one patient in particular where I really got it wrong, and people often want to know, you know, how long will it take for this to get better? And I remember this particular person where I mean, this is years and years ago, but I remember still saying, well, you know, given what we found, I believe that in the next 6 weeks, you should be in a much better place. We should be doing this, that, and the other. And they weren't at all, you know, way off that. And I remember driving home after me guessing and just going, I don't think I've got that right. I think I'm way off. And, God, and I was so confident saying in the next, but it was a brilliant learning curve to just go, right, next time when I'm giving out this advice, I need to be aware that I could be wrong, and I was. It turns out I was wrong. So, not all bad. That's although there was an error in my judgment there. It wasn't all bad. It was a way of me learning, and I think that these are sort of simple experiential processes that we can go through ourselves, or we can get our patients to go through as well.
Totally. Yeah, I see that. It's quite interesting, just reflecting on your own education and reflecting on your patients, which I totally second you on the fact that I had probably said, even think of the bad feeling you have whilst you're driving home, like, oh, I don't think got it right. I might have, and in most cases, you have been basically reassuring where you didn't feel comfortable with it. So you're probably trying to do better, trying to give reassurance by probably selling uncertainty, which is a really interesting thing where I started realizing that it's probably not where I want to spend my professional life in doubt. And since I felt much better with not knowing and being honest about it, because that's probably not what you're going to take to bed
Yeah.
as a part. And it may also trigger you that I should know more about this, right? And you think, well, I probably should know more about it because that's what expected from me. And I've got this, we have a few interns here in the clinic, which is a lovely way of reflecting your own clinical work and years in the past, where even though they sometimes do play around with uncertainty and telling, I don't know, you sometimes take the wrong angle as well. So because you don't reassure them and you don't have the answer, they feel uncomfortable. And we had a few examples recently here in the clinic where it definitely created a little bit of let's say a grumpy person said, well, I don't know this word, I don't like this treatment, it's all about we don't know. And obviously that's not where you want to go. So that's something else that needs, and it may not, he may be or the person, the intern, made it totally right in the way they have it. And that's it.
And that might, it might come down to the way that someone is thinking as well. So you might be in a really good way, using quite divergent thinking to understand a complex problem, where that person is more of a convergent thinker and looking for the black and white answers. And that does happen, doesn't it? That we're not,
Yeah,
we're not quite on the right levels. So yeah. I think then there's an importance there of not losing trust. So recognizing that, we need to be working on we need to be working and finding a shared level to be working at with these
totally.
people.
Yeah. All right. So I think this is a subject that we need to push a bit further, and let's make sure we're going to cover some other aspects of uncertainty and how to handle it for next episodes. And I think that this is probably a good start, because we planned out a whole series of conversations that we think gonna be very clinical relevant, and therefore building upon this whole series. So looking forward to the next episodes. Yeah. So I guess that's probably where we are now. I just wanted to give a bit of a summarize. So just from a clinical point of view, I think uncertainty is quite normal. Don't feel uncomfortable with uncertainty. That's a process of basically making sure you know your stuff, obviously, but you can also train yourself in dealing with uncertainty. CBT has been a great framework for that. Really love to deeper dives into to the flexibility that we need to deal with that in patients. And I'm pretty comfortable that we can do a much better job if we focus on those strategies that can make your life as a therapist much easier, and probably your patients as well.
Yeah. Awesome. Thanks, Bart.
Thanks, mate. See you next time.
See ya.